So I trained at Glasgow University, and when I graduated I wanted to be an A&E consultant, and as part of my training for that I did placements in anaesthesia and in surgery. And I realised that I really liked high-end medicine, so I liked seeing trauma and I really enjoyed looking after people in life and death situations. But I didn't like not knowing what happened to them. So when they moved on out of the department, what was the management after that? I really liked anaesthesia, but I preferred watching the surgery and I was fascinated with what the doctors were doing. So I very quickly decided that I would change tack to surgery. And I was placed in cardiothoracic surgery for my first 6-month rotation. And I was told, it's a really great place to go. You'll harvest vein, you'll get good surgical skills, and you'll be a good surgeon by the end of it. But I just loved it. I just thought, I'm not changing, going to general surgery or anything, I'm going to stay with this. So I then moved on and did some vascular surgery, and then I was appointed through national training to be a cardiothoracic surgeon, and I spent 6 years in training. And I was appointed to Northern Ireland and to Newcastle for my training, and then I got a consultant job at the end. I like heart surgery because you can return people back to their normal quality of life. You can even improve it. And it's not with any caveats. Sometimes in general surgery, a lot of your work is in cancer surgery. And I just find that it always comes with, you make people feel a little bit more symptoms than what they had before, but you're doing it with a goal of curing cancer. And in heart surgery, you can actually improve quality of life. And I like that aspect to it. So I'm a transplant and cardiothoracic surgeon, so I do lung and heart transplantation. I specialise in major aortic cardiac surgery, and then I also perform bypass operations. So I think we've seen a real change in heart valve disease over the last century, and I know certainly if I had trained in cardiac surgery maybe 50 or 60 years ago, I'd be treating completely different pathology. So we've moved much more away from rheumatic heart disease and much more into degenerative heart disease. So it's a natural process of wear and tear of the valves, and it affects a significant portion of the population. And as health in the population improves, then the age at which these patients present is at an older age category. So you see a lot of degenerative aortic valve disease and degenerative mitral valve disease and the consequences of that. And I think it's really fascinating that you can replace a valve but also improve someone's heart function. So over time what happens is that as the valve is completely worn, it's no faulty or no longer working as well, the patient ends up with heart failure and the heart muscle stops pumping as well. So to do the valve replacement actually can either improve or regain some of that function or prevent it from ending up in heart failure. And heart failure in the UK is probably as big a killer as cancer is. It's just not as well publicised. So treating heart valve disease actually is preventing heart failure, and it's preventing a lot of patients dying from a really miserable way of ending your life. As in heart failure, it's very difficult to breathe and it's difficult to move around. And I had a great aunt who died of heart failure, and I think anything we can do to prevent that is a good thing to do. Well, so the British Heart Foundation are really trying, and I think that it's like all these things, sometimes it needs a little bit of a celebrity effect. And we all know very much about breast cancer because of celebrities who've had breast cancer. But we don't see many well-known faces that come on television and tell us about heart failure, and I think that's just the way it is. But I think that certainly if we could improve patient advocate groups and we could encourage patients to talk about it a little bit more, then probably we would know much more about it. What's really exciting is that there's so many options open to patients. So rather than it just being, well, you can either have open heart surgery or you can have nothing really for severe valve disease, we've now got transcatheter therapies, and I think that really opens the bracket to who can be treated, and it makes it much more open. And we saw that in lots of publications. Whenever we introduced TAVI, which is transcatheter aortic valve implantation, we actually saw that we treated more patients. So we didn't stop doing as many open heart operations. What we did is we treated more of the population and we prevented more of the population dying as a result of severe aortic stenosis, and that, I think, can only be a good thing. It doesn't surprise me that patients come and think that they'll be given the best and there'll only be one thing that is suitable, because that's the way all healthcare in life sort of works. You have a problem, you go to a doctor, you get told what it is, and you get told what the treatment is. So I think specific to heart valve therapy, it's important for patients to know that there is a choice. No matter what is recommended to you, it's you that has to live with it, it's you that it gets implanted into, and it's you that has to take care of it. So it's really important, I think, that the consent process is much more informed. So it should be you and your surgeon making that choice together, because it should rely on what you need and what your lifestyle dictates for you to have. So guidelines for heart valve therapy are very much directed by ages of patients and what they would recommend depending on patient age. So it's based on how long the valve will last, when it will wear out, and the guidelines are always based on the evidence that they have at the time. So when new therapies come along, it actually takes a long time for that therapy to be considered in a guideline, and it's very difficult for guidelines to be changed on a year in and year out basis because they're big committees, lots of different doctors together. But broadly speaking, if you need valve replacement surgery, you can either have a mechanical, so a completely man-made device, or you can have a more natural tissue valve implanted, and those are the two main categories. So it's about understanding what each of those offers you and what the caveats to those would be, and then I think it is ultimately the patient's choice and always should be the patient's choice. So the mechanical prosthesis is one that requires blood thinning agents. So you need to take a drug called warfarin alongside having a mechanical prosthesis. But the mechanical prosthesis is designed with paralytic carbon, and it's a very solid structure. So in actual fact, the ability for that to wear over time is much less. So once it's implanted, then it should remain in situ. Alongside the warfarin, the mechanical valve also does make a noise. So it's very similar to what you would hear on a clock face. If you've got a clock and you held it up like your watch close to your ear, that tick that you hear is the mechanism of the valve when the blood flows through it. So those are the two things about a mechanical valve. If it's something that you just feel that you really would want to try and prevent ever needing to have another intervention again in the future, then a mechanical valve will definitely be for you, because that's the valve that we can say that that's true with. A tissue valve allows you not to take warfarin, so it doesn't come with a caveat of requiring any drug therapy for afterwards, but it will wear because it's made of pericardium, and so pericardium is a structure which will calcify over time, so it will wear and tear in the same way that your own valve has worn and torn over time. So you need to accept with that if that improves your quality of life because you don't take warfarin, then you accept that with time you will come back and are more likely to require an intervention. So I have never had a heart valve operation, and all the advice that I give to you is based on literature that I read and the patients that I meet and I come across. So all I can tell you is that some patients, unfortunately, despite having made their choice, because the rate of infection of the two valves is exactly the same. So if I think of an infected valve, it's probably the best way to describe it. So someone who has no choice, that valve has acquired an infection, they have had a dental procedure, something has happened that bacteria has got into their bloodstream and infected that valve. So that valve has to come out. And I've quite often heard patients say after that it isn't as bad as what they thought it was going to be. And I think that's the secret. If you arm yourself with as much information as possible, so ask questions like, how long before I can drive again? When will I be back to work? How much will my blood count drop? How anemic will I be? How tired will I feel? And once you've gone through it, you'll see that actually it's not as bad as what you have in your head or what you think it's going to be. You shouldn't sign a consent form for something if you don't understand what it is you're signing up to. We wouldn't go and buy a new car unless we knew the make of it, the model of it, the colour of it, what its performance was. If it didn't come with a recommendation, some people like to trust the brand they've bought before. Some people go and ask people who have bought that car, how did you find it? How does it run? How often does it go to the garage? And I think sometimes healthcare gets a little bit left behind in our mind, and it's about encouraging people to say that actually you have choices, and so you're allowed to make informed decisions, and what you would do in the rest of your life, you should apply that into healthcare as well. So you should know what tablets you take, you should know what your medical conditions are, and you should try and be involved in some of your care. So you should, want to know information about why people are giving you things or why they're telling you to do things. And
Once you've come back.
and that happens, and that is okay. But then you have to accept that that's the path that you've gone down, and that's the way you've decided to treat it. And I do understand that. You know, you can be. I remember my own brother-in-law had a heart valve replacement about 18 months ago, and I still couldn't concentrate in the morning that he had surgery until I got the phone call to say it was okay. And I knew it was going to be fine, and it was fine, but that doesn't mean I didn't worry about him when he was there, and that's perfectly understandable. And that is why you don't make this decision on your own. That's why you've got someone like me across the table you can talk to, we can give information, and we can go through things like what's your lifestyle like, well, how active do you like to be, what do you want to do, and talk about which valve will suit you better for that reason. Because you can avoid warfarin as a therapy, then it will allow you to do things that I probably wouldn't recommend if you're on warfarin. So again, that'll depend on your health when you come forward for your valve replacement, because there can be other reasons why you're on warfarin therapy. So it might be that you're on it anyway, and then it doesn't make any sense to avoid it because you're going to be taking it or have been taking it for a certain period of time, which is why it has to be very much a very dynamic conversation, and it can't happen over 10 minutes. We need to know a lot of information about you. Not just about your heart valve disease, but we need to know about your background, what do you work at, you know, what are your hobbies and your activities, how much alcohol do you drink. There's so many factors that go into this. And then that's how we as professionals make that decision and help guide you to the right decision.